All right. Hi, everyone, and welcome. Thank you for joining us on today's webinar. For some background, Delta Omega is the Public Health Honorary Society and was founded in 1924. There are currently 132 chapters at CEIF-accredited schools and programs of public health, which have inducted over 30,000 members. Again, founded in 1924, we're excited to be celebrating our 100th anniversary this year. And one of the ways we are celebrating our anniversary is by hosting a series of webinars looking back at the past 100 years and featuring a public health milestone for each decade. We've made it to the 1990s, and this decade is being presented by the Delta Nu chapter of University of Texas Medical Branch School of Public and Population Health. Their topic is 1990s in Hispanic Health and Aging. It will be presented by Dr. Kyriakis Markides, Dr. Rebecca Wong, Leslie Stalnaker, Brian Downer, and students Ornella and Mariella. And I will pass it over to Leslie.
Awesome. Thank you so much for that introduction. I'm going to go ahead and share my screen. Okay. So thank you all again for being here today. It means a lot to us to have the opportunity to share about some of our work at UTMB and this platform. We know everybody's really busy, so again, thank you for being here with us today. I briefly wanted to provide an agenda, so I'm here to do the welcome and the overview. You will then be hearing Dr. Markides talk all about the Hispanic established population for the epidemiological study of the elderly study. He will be joined briefly by Dr. Brian Downer and PhD student Ornella, who uses some of the data for her own research. After that, you will be hearing from Dr. Rebecca Wong, the PI for the Mexican Health and Aging study, and another PhD student, Mariella, will be speaking about how she uses the MHOS data in her own research. And then after, we will have about 10 to 15 minutes at the end to address any questions. So please feel free to use the Q&A box throughout the presentation if you have any questions that you would like us to answer. I briefly wanted to do a little overview of who we are, since we're not necessarily one of the more popular names in the schools of public health. The UTMB School of Public and Population Health is located in Galveston, Texas. We are about 50 miles southeast of Houston, right on the Gulf of Mexico. I put this picture on the bottom right to make everyone a little bit jealous. Our campus is just a 2 to 3 minute drive from the beach, and it's a beautiful place for us to live and to work. We are a fairly new school of public health. We received full accreditation from CEPH in December 2023, so just a few months ago, but we were an accredited public health program since 1999, so we've had our accredited MPH programs for a few decades. We currently have 5 MPH concentrations. We have a few other master's programs, including an MS in aerospace medicine. UTMB is fortunate to have an aerospace medicine residency program, which does a lot of really interesting and cool stuff with NASA and private industry. We also have 3 PhD programs, and the 2 PhD students who are with us today are both in our population health sciences program. A little bit about our chapter. We're a fairly new chapter. We started in 2018, and we currently have 84 members. We're looking forward to growing and to doing more as a chapter in the coming years. So I briefly wanted to frame a little bit about why we're here and why we're talking about this topic in the 1990s, since for many of us, I don't know that Hispanic health and aging is something that we automatically think of when we're talking about the 1990s. All of this really got started because in the early 80s, the National Institute on Aging funded the established populations for the epidemiological study of the elderly, which then led to the funding of the Hispanic APC that Dr. Markides is the PI of today. It started in the 1990s, and then the Mexican Health and Aging study really started as a call for funding for longitudinal studies on global aging that came out in the mid to late 1990s. So that was really when both of the studies that we're going to be talking about today really started. So I will hand it over to Dr. Markides, who will be talking about the Hispanic APC study.
Thank you. The Hispanic EPIs, for short, it's been around a long time, 32 years. It was funded in 92. Originally, with the idea is to get basic information on the health status and healthcare needs of the Hispanic population. We proposed to study of Mexican Americans in the Southwestern United States because That's what we have done a lot of work in, and it's the largest population, in 2/3 of the Hispanic population of the United States. Here's a list of all my colleagues. I want to just say Brian Downer, who is here helping me with some of the presentation. And we also, next slide, please, some colleagues in San Antonio and Austin who've been part of the study for a long time. So a lot of people have been part of the study, and it's been going on for a long time. And I'll show you in the next slide. First of all, how we selected it. It was selected using an area probability sample of the southwestern United States, 5 states, where you select counties, you select and the census tracts within them, city blocks and households, in a systematic manner to get a representative sample. And we got 3,050 people. And as we follow the sample up longitudinally, which is really important to studies of aging, we added 902 subjects at wave 5 when everybody was actually 75 and over. And I will show you the specifics of the numbers very briefly in the next slide. And we began with 3,050. You can see on the left how the numbers diminished until wave 5 there in 2004-5 when we added that. So we had a replenished cohort of 2,069 people. They were all 75 and over. That's where the problems are concentrated, right? And then having a new cohort, people 75 and over, we were able to study trends in the health of the population. And we found some very, very interesting findings. And you will see we have 9 waves here. Wave 10 was kind of abbreviated by the pandemic. So we'll talk about that toward the end. But next, I will give you like a model of the study. You know, this is like most studies of aging. This is what you study. You know, in the end, longitudinally, you study mortality, the predictors of it. We've done quite a bit of that. And then we study the quality of life, basically, in terms of the functioning of the people. Cognitive function is becoming increasingly more and more important, and taking over from physical function and disability, but also emotional function. And all these, you know, interact with each other to influence outcomes and influence each other. And, you know, as you move backwards, you see medical conditions predict these sensory impairments. And then there's social factors, stress, and the socio-demographic characteristics. The community context came in aging and really in studies of health in really more recent decades, where we went beyond just asking people about their lives and so on, but also finding out about their communities, where they live. It's become a very important part of what we do, the community, the neighborhoods, and so on. And a lot of advancements in that area in our work and in the work of others. Next, I will summarize something. People ask me, what have you learned all these years about this population? Well, one of the things that we know based on our studies and really the studies of other people is the Mexican American population is long living, really longer than the general population, about 2 or 3 years. And but it is characterized by higher levels of comorbidity, disability, and cognitive impairment, especially so. Brian would speak about that. And there's really, more importantly, strong evidence of increases in disability and cognitive impairment at ages 75 and over from the early 90s, our baseline, to 2004-5 when we added a new cohort. And this was especially so among women. And it was primarily due to increases in the prevalence of diabetes and to some extent obesity. But there was a tremendous increase in prevalence of diabetes, which was good news. People were controlling their diabetes, the doctors, families. But the negative aspect, it causes problems like disability and cognitive problems. So another thing is the overall findings really, if I can generalize, support the Hispanic epidemiological paradox, which has been a big part of the Hispanic health literature in the United States and extends to other groups also, but also extends to Australia and Canada in some of the work we did. So there's a healthy immigrant effect that we can see in other countries as well. The next slide is one of the important things we have contributed for a long time is that I mentioned the community context. When we looked at neighborhoods, so Hispanic neighborhoods in particular, the more Hispanic density of the population, Mexican American density, had benefits for the population with respect to mortality, emotional and cognitive health. Our colleague called it, Carl Expert called it the barrio effect, like other people talk now about the ethnic enclaves as the benefit of living in ethnically homogeneous neighborhoods, but it is something that the field is evolving. One of the things we also did is we tried to predict who's going to make it to age 75, and there were some interesting findings. We found that the strongest predictor of all was not having diabetes, which is a major problem in this population, and also not having hypertension. Depression, interestingly, is a very powerful variable, and not being foreign-born consistent with immigrant health selection. But we even found at this age, people very old, that smoking is still an important variable, but also being underweight, which seems to be another major predictor of good health. And obesity was protective of the mortality in our population, but and really in all Americans, based on the work of my colleague, Dr. Osney. Then I believe the next slide is some recent work that Dr. Browner has done. And if you don't mind, Brian.
Yeah, thanks, Coco. So,
closer.
yeah, Cocos was mentioning that the Hispanic EPIs has been a valuable study for research on cognitive aging and dementia among older Mexican Americans. An interesting finding, and actually I won't go into too much detail here because I know Mariela is going to be presenting on some of this work in the Mexican Health and Aging study, but looking at the role of occupation and how that contributes to older adults' cognitive functioning. So evidence from this Hispanic EPIs would suggest that lifetime employment in agricultural occupations is associated with higher risk of cognitive impairment, but there seems to be gender differences. So that effect seems to be stronger among older Mexican American men. For women, it really just seems to be participating in the labor force has benefits for cognitive functioning later in life, but in particular, employment in skilled occupations. One of the kind of unique things about the Hispanic EPIs is, this was maybe 6 or 7 years ago, maybe even longer, the survey data was linked with Medicare claims files. And so that really expanded the scope of the study because now we had really detailed survey information from participants, but we also had really detailed information about their healthcare utilizations and what types of medical conditions they were being diagnosed with. And so we used this linked data set to show that about half of the participants age 75 and older had dementia at some point during the study. It's likely that's possibly an underestimate, just given some of the limitations of detecting dementia in Medicare claims files. The last finding I'll highlight here is evidence just showing that older Mexican Americans living alone are more likely to have impairment and dementia. And so it really just raises concerns about how older adults are having their long-term care and dementia care needs met. You can go to the next slide, Leslie. And this will be my last slide here on this kind of selected finding. So Coco's mentioned just how powerful the Hispanic EPIs has been for research on migration. And there's just been a lot of really interesting research on how the health of older Mexican Americans varies based on whether they were born in the United States or Mexico. And among those born in Mexico, what age did they come to the United States? So Mark Garcia and others have done a lot of really great work looking at how mortality is different amongst those people born in Mexico versus the United States. And while women tend to have a mortality advantage, it doesn't necessarily mean that that longer life expectancy is spent in relatively good health. So evidence suggesting that women migrating later in life may actually live longer with depression than US born women. You can go to the next slide, Leslie. Just to wrap up, so as Coco's mentioned, the study is in a bit of a transition. So in wave 10, the field work had to be paused because of COVID, and we were able to go back out into the field and conduct telephone interviews with a small number of caregivers and participants. It's led to some interesting data, even just descriptively, of how COVID affected this unique population. And data for this is still being analyzed. We're excited though, because we're also in the process of writing a renewal application. And this is really motivated by two things. One, it's to establish a new cohort of about 2,000 Mexican Americans. They'll be age 75 and older, again, living predominantly in the Southwestern United States. One reason we're interested in doing this is just looking to see how trends in population health have continued to change. So after this next wave of data collection, we'll have had data from independent birth cohorts of adults age 75 older in the early 90s, mid 2000s, and then the mid 2020s. And so you can just imagine all of the different things that have happened over the course of that period that might affect older adults' health. The second reason we want to go back into the field is really just enhance the study's infrastructure to gather more novel data. We're especially interested in enhancing the measures of cognitive functioning, as well as incorporating novel data linkages looking at environmental health and environmental exposures and how those types of things are affecting the health of older Mexican Americans.
So, I mean, climate change is hard to really ignore anymore. And we're going to try to do our best. If we get funded, hopefully we will. But thank you, Brian. Mm-hmm.
Hello, hi everyone. I am very happy to share some preliminary findings, highlight from a research project that I've been working, or I'm still working with Dr. Cantu, really exploring caregiving dynamics and life space mobility using the herpes study. Next, please. So life space mobility, what it is a critical marker of functional independence and overall well-being in aging population, really reflecting people's abilities and patterns of movement and engagement with the environment. And on the flip side of it, in terms of on the other hand, caregiving involves really various forms of support, and its effectiveness and nature really can vary based on caregiver attributes. And we had this concept of linked life, which was really critical to understand caregiving dynamics and impacts on life space mobility. And linked life is essentially the idea that individual life are intertwined with those of others through social relationship, such that caregivers and care recipients are part of each other linked life, influencing and shaping each other opportunity, experiences, and outcome. So we have found in the literature studies on that have explored the roles of life space mobility in predicting health outcome, including mortality and morbidity and healthcare utilization among older adults. But there seems to have been there's a research gap in understanding how specific caregiver attributes or caregiver characteristics contribute to positive life space mobility outcome, particularly among the Hispanic older adult populations. So hence the interest in exploring this area. So we hypothesizing that caregivers who are more physically capable, such as youth or young adult, will provide greater support to older adult, and consequently that will lead to positive impact to their life space mobility. Next, please. So the analysis was conducted, or is still being conducted, using data from wave 7 of the herpes studies. Our outcome variable here that we're exploring is mobility, but specifically we're looking at the validated life space mobility tools. It's a tool that has been that has been used back in, it's not really a new tool. It's a tool that has been used back in the 1900, I believe, and it's operationalized into 5 life space levels as listed on the slides here. So scores for each level were multiplied and summed to really derive the overall score, and that ranged from like 0 to 120, with a score of 120 indicating that the highest level of life space mobility that someone can achieve, and that really corresponding to activity that are traveling outside of the town without any kind of sort of assistance. Independent variable included caregiver demographic characteristic, including the age, the sex, the relationship, the depressive symptom that was operationalized or assessed using the CESD scale with a cutoff score of greater than 60 or greater or equal than 60, meaning that they are depression and then self-rated health. Covariate also was selected with based on care recipient factors known to impact mobility in aging, and that included age, sex, depression, self-rated health, disability, and cognitive impairment status. So to answer our hypothesis, we generated ordinary least square regressions to answer our research hypothesis. Next, please. Again, these are really high level sort of preliminary finding so far. So we're still looking and exploring the data. So far our total sample size is 861 participants. We have noted a participant who reported moderate life space mobility with a mean score of 36.8. The majority of the participants, both in terms of care recipient and caregiver, we are seeing here that they were female and they reported a high prevalence of poor health and a moderate to high depressive symptoms. When we looked, and apology, we didn't really include numbers specifically here, given that we're still working on the analysis itself, but looking at the data so far in our multivariate analysis, and when looking at all caregiver, being a spouse had a significant positive impact on life space mobility, and this suggesting perhaps that spouse caregiver really giving the intimacy knowledge of the partners, of the needs of the partners, that may probably lead to more tailored kind of support. And when we are adjusted for care recipient characteristics specifically within the model, the relationship between caregiver characteristic, specifically age, sex, and caregiver health, and disability and depression, they were not found statistically significant. So one way to interpret here is that while caregiver attribute may play a role in caregiving dynamic, they may not directly influence that life space mobility outcome of the care recipients. And when we specifically when we are restricting our analysis to caregiver who are children and not spousal or spouses, older age, being a female or sex, higher level of depressive symptom, dependency of activity of daily living, and the presence of dementia or cognitive impairment have been associated or is associated with lower life space mobility. So there's still a lot to unpack in this analysis. So more to come. So these are just some preliminary findings, and we're hoping to include other variables of interest to see really how the relationship between caregiver characteristic and life space mobility of older adults are playing out. So that's it for me. Thanks. Over.
Hello. My name is Rebecca Wong, and I'm going to speak to you about a longitudinal study on aging in Mexico and the potential for public health research. Next, please. So in the decade of the 1990s, early 90s, scholars started to recognize that aging was going to happen very fast in middle and low-income countries as a result of the success that we had in adopting in the 1940s and 50s the hygienic medical technology measures that reduce mortality and reduced fertility around the 60s and 1970s in Latin America, in particular after Asia, and then later it would happen in Africa. So recognizing that there would be a very fast aging of the global population, then we started to think about the importance of providing research on aging under these conditions of poor and not too many institutional support for high old age, and so how these conditions would present in aging of the population. So we started and proposed to start a prospective national longitudinal study, so it would be representative of the population of Mexico, and it would be longitudinal in Mexico. Mexico is a country of 130 million people, about 3 times the size of Canada, and about 2/3 the size of the United States. It's a large country. We would follow adults age 50 and over until death, again, a representative sample. There would be an exit interview after the person would die, the participant dies, to understand the last year of life. Couples would be followed to understand how the life in couple and then in widowhood would affect aging. And then there would be oversamples of migrants to the United States because it's a large component of the dynamic of the population between the two countries, that the aging of the two countries would be linked as well. And the study would be highly comparable to the US study that started before, the US Health and Retirement Study. For those of you who may be familiar with this, the MHAS, this Mexican study, is very similar to the US study. Next, please. So fast forward 20 years, and this is where we are. We started following this representative sample in 2001. If you follow from the top left arrow, we recruit about 15,000 people are interviewed in every wave. But in 2001 and 2003, we followed this sample, and then we had a hiatus in the study, and then we restarted following the same people in 2012. In 2012, we decided to follow the study from then on every 3 years and add new sample to replenish the sample every 6. So we added in the green arrow on the top, new sample was added of those born in 52 to 62, and we started to follow them as well as the red group that we had. And then we followed them 2015. In 2018, again, we added a new sample of those born in 63, 68, and we started following, continue following the others. And then we conducted 2021, right before Omicron, we conducted one wave, and we're about to conduct 2024 this fall. It's important to signal here that after 2021, we already had a cumulative mortality of 7,400 people that had died in the study. So it has become a very critical longitudinal study of mortality as well. Next, please. So very quickly, the well-being in old age is the central piece that we want to study, but we take a look from the life course perspective. So we inquire from people their childhood conditions, their history of health, and their history of migration, employment history, but also migration history, the public transfers they receive, if they have pensions, anti-poverty programs, the services they use, the healthcare services in particular, the family where they live, who they live with, that network they have, their private transfers. That means that if they receive help from their family, their income and assets, and then also, of course, the health in middle and old age in many dimensions, and of course, the demographic traits. On the left, it just shows the evolution of the study. As by wave 3, we started gathering some biomarkers in selected subsamples because of the cost. We rotate and select who gets biomarkers, but we have collected till now samples in blood-based biomarkers, saliva-based biomarkers, and samples of hair to also look at heavy metal exposures, and in particular saliva and blood to look at genetic analysis of Alzheimer's. In addition, we add the historical context, as Cocos was saying about the Hispanic EPIs. We look at the environment, the neighborhood, but also a historical then that it's possible then to link the survey data as you follow them over time, you link with the historical series of the healthcare services that have been added to the community, the historical series of mortality by cause, and also looking at the exposome, the air pollution, high and low temperatures, droughts, and so on, that are now, of course, something that we need to study, as we're saying, because of climate change. So again, the study has evolved, and we've been able to add all these additional data. Next, please. So I wanted to highlight that the study has many products, and you can consult them in their website, and there's a website of the study. But we wanted to highlight one data product in particular for beginners, because this may be useful for anybody who's thinking about using this data sets. We constructed this especially for the classroom or beginners users. So it's called Simple MHAS, and it has the following features. It does the longitudinal panel, so you have the 5 waves from 2001 to 2018. We're currently adding 2021. So that is altogether about 76,000 observations across time. But you can just, you follow people along the waves, or you can just choose to take one wave and do a cross-sectional analysis. And so this is a very easy way for you to start in being introduced to the study. It includes information about which wave each individual participated in. If it died, there's an indicator for if that in that particular wave then that person is reported dead. It's in the long format, but it's easy to convert it to wide format. And important to say, we select about 80 constructed variables in each wave. So we just present those 80, and that's what we give you. You don't have to go through all the hundreds of variables and questions that are asked in each wave. Next, please. So very quickly, this selected variables include demographic, the support network that they have, the health in, like I said, several dimensions, including mental health, physical function, and so on, and chronic diseases, economic conditions, use of healthcare services, time use, whether they do volunteer work and do other activities, as well as cognitive function, which is now very important for our studies on aging. And so this is, again, a very quick look of these Simple MHAS product that you can find in the website. Next, please. So I wanted to show this map. This is the map of the role studies that are comparable to the MHAS, which started to being comparable to the health and retirement study in the US, as I mentioned. And so we are now part of 40 countries in the world that have very similar studies. The MHAS, the Mexican study, was the first one that followed the health and retirement study in the US, but then after that, other countries were added. Right now, we're starting to look at several countries in Africa. You can see the empty space right there. Several studies are just beginning to be started, as well as in South America. Next, please. And this is just a thank you, just to provide the idea that we don't forget that this data, who's given it to us and how generous their respondents are. As I said, these people, in order to make a representative sample of Mexico, we have to interview them at their homes. And the Statistical Bureau of Mexico, the National Institute of Public Health, has been very useful, very valuable collaborators for this study. Next, please. Just quickly, just wanted to tell you that if you go to the website, you can find a list of publications available of authors that have used the data. So you can find 443 products there that we can document. It's probably there are more out there, but we can document 327 peer-reviewed papers, 64 dissertations or theses, and 52 chapters of books. And they are by keywords. So if you want to just look at, say, income or depression, then you can look for those keywords and find what their authors signal as keywords in their work. Next, please. Just wanted to highlight, there's no way to highlight all these publications. So one highlight is that what we've been able to see is that the younger cohorts that enter middle and old age are entering in worse conditions than the earlier cohorts. those who entered, say, age 50 to 59 in 2001 were in better condition than those who entered age 50 to 59 in 2018. And this signals an evidence of expansion of disability, meaning that instead of generations living longer with less disability, the cohorts are looking with increasing physical limitation because there's in particular a rise in obesity, cardiovascular and cardiometabolic conditions in the successive cohorts in Mexico. And these conditions are very similar to those in many other countries in Latin America. And this is what we are starting to learn from studying cohorts like the Mexican population, in saying this may happen in other countries as well that present similar conditions. Next, please. Another overall finding is that the aging in Mexico continues to be closely linked to the US. Just quickly to say that approximately of men age 60 and older, approximately 16% are former migrants in the US. So they used to be workers or who worked or lived in the US, and now they're back in Mexico. About 16% of males. And this was true in 2001, still true in 2018. And among men and women who have at least one child living in the United States, among those age 60 and older, it's about 30% in 2001, 24% in 2018. So the two countries are closely linked, basically because the population in Mexico who are older were part of a migrant network, but are currently still part of that migrant network through their children. Next, please. We just celebrated 20 years of follow-up, and now our new emphasis is on using the data and making sure that other people in the scientific community can use the data. Wave 7 and 8 are planned, they are funded for 2024 and 2027. The data is available for downloading in Spanish in that website and in English. And this is a long-lasting collaboration between Mexico and the US. The National Institute of Statistics is our long-term partner since Wave 1, and they continue to conduct the study with us. And we have many other collaborators in both countries. Next, please. So this is it. Thank you very much. If you have questions, please write or ask in the chat. Thank you.
All right, we'll pivot to some student-led Mexican health and aging study research. My name is Mariela. I'm a fourth-year PhD candidate in the Department of Population Health and Health Disparities here at UTMB at the School of Public Health. Next slide. The title that I've given to my dissertation work is The Influence of Lifetime Occupation on the Health of Mexican Older Adults. And this project kind of marries different interests that I've had since my master's degree, where I started getting interested in the influence of occupation on the health of Latinos. But then I started getting interested in aging as well. And here at UTMB, I've been able to merge both of these two interests together. The Mexican Health and Aging Study collects data on lifetime occupation. This series of questions are asked at the first interview of participants, as well as a lot of health outcomes like Dr. Wong highlighted are collected. More specifically, cognitive functioning is something that has been very well collected throughout the years at each wave for each participant. And mortality with the exit interview is also collected in the Mexican Health and Aging Study, as well as other sociodemographic and health characteristics. But my main research interest has been what is the effect of lifetime occupation on two outcomes, cognitive function and mortality or survival. Next slide, please. So I'll highlight two of my studies that kind of surround this topic of the socioeconomic impacts of the health of older Mexican adults. So this first one is highlighting mortality differentials by lifetime occupation. So what we try to achieve with this project was to study the association of occupation types and mortality by rural versus urban dwelling in Mexico. And we used data from 2001 all the way to 2018. And we did Cox proportional hazard models and Kaplan-Meier curves to study the effects of occupation type on mortality. And it is aggregated by urban rural dwelling. And we found that in both rural and urban settings, participants with manual jobs such as agriculture and production and industrial type of jobs had an increased risk of mortality compared to jobs that were held in the administrative and professional fields, which is what we expected. But we found more disadvantage in the rural communities. We also found that in urban settings, participants in domestic and service categories had a higher risk of mortality than those in the administrative professional categories. The figure on your right exemplifies the disparities of survival by occupation type. And these findings highlight the effects of socioeconomic determinants on life expectancy, specifically looking at occupation. Next slide, please. So, like I mentioned, cognitive functioning is another topic that I have been interested on. And actually, my dissertation focuses specifically on looking at cognitive trajectories of cognitive functioning in the Mexican health and aging study. But my first project related to cognitive functioning and socioeconomic factors was this one, looking at the role of education and occupation across differences in birth cohort differences in cognitive functioning. This study examined cognitive function differences between two birth cohorts of Mexican adults, age 60 to 76, one in 2001 and the other cohort in 2018. We wanted to study how population level changes of education and occupation have impacted the differences in cognitive function throughout these two birth cohorts. Because we know in Mexico, there's been an increase in educational attainment. And as we know, depending on the education you get, you'll get a certain level of occupation. So there's been occupational changes in Mexico as well, with a transition from more manual jobs to more skilled or administrative professional type of jobs. So we used data from the Mexican Health and Aging study, and we found that increases in educational attainment and shifts in these occupation types explained the improvement in cognitive functioning in more recent cohorts of older adults. Actually, education accounted for more of this difference, with occupation having a lesser mediation effect on the difference in birth cohorts in cognitive functioning. We also found difference by genders. So the mediation effect of education and occupation was larger for women than men. So we clearly need to understand these, how the early life determinants of cognitive functioning vary by gender, and as well as birth cohorts. So next slide, please. Some of my future work with what Dr. Marquides and Dr. Wong have highlighted, the advantage of using these studies is you can study trajectories of health statuses. So I want to examine trajectories of cognitive function and the influence of one particular aspect of occupation, which is mental demand of work. The Mexican Health and Aging study was recently linked to a data set that allows us to study more descriptors of occupation rather than just occupation type. Mental demand is one of the descriptors that we're now able to study. So my future dissertation work will examine how mental demands of lifetime occupation impact trajectories of cognitive functioning. And I did want to look into the gender differences of this relationship a little closer. So I hope to study how family work dynamics by gender impact the trajectories of cognitive functioning in the future. So that's all that I had to share with you today. Thank you for the opportunity of talking about research going on here at UTMB.
Awesome. Thank you, Mariella, and thank you to everyone who presented. I think now we're ready to move into the Q&A portion of this. So you can use, I think there's a Q&A feature if you want to use that, or you can also put questions into the chat. It looks like there might be a few questions. So this is for both Dr. Marquides and Dr. Wong, if you both want to turn your videos on so everybody can see. One of the questions is, what are the main aspects of aging that can be studied uniquely using the MHAS and the HAPIS data?
Yep, you want me to go first, Cocos?
No, you go ahead.
Okay, I would say that uniquely is the part about former migrants to the United States and being able to have a large number of people who were former migrants in the US and now they're back in Mexico, and people who have family in the United States and they are in Mexico. So being able to study how aging proceeds in countries in which there's a high codependence with a higher income country in this way. The other unique aspect, I think, is that if you think of the genetics of the Mexican population, the ancestry is a very interesting variable because it has a mixture of American Indian with Spanish. And so in the whole spectrum of variation. So there's a variable there that we have already available for the genetic analysis of genetic variables. We have ApoE4 ancestry, and so in a couple other variables. But this is a very unique ancestry, and having a large sample, we have around 8,000 samples of genetic analysis and DNA, and being able to look at ancestry in this population is exciting. There are other studies with populations, say in the Caribbean or other populations that are more homogeneous, whereas the Mexican population is very heterogeneous because there was so much mixture. And it's, again, a large population. Thank you.
Well, with the Hispanic EPIs, I guess the uniqueness is the largest study of the Mexican origin population in the United States, and really following it up for 30 years. Right? So, getting trajectories and learning a lot of things about people's lives as they get older, but also adding a new cohort halfway enabled us to study trends, and that's kind of a unique thing in studies of aging. And study of trends is so important for policy purposes, and that's what we hope to do really by adding a new cohort again of very old people, and to see if the increasing problems and disabilities and cognitive problems in the population will continue into the future, or will maybe stabilize as they have in the general population. So we're very excited about the study and its findings, and possibly the future. I mentioned policy, but also really related to policy is the need for how families provide caregiving to very disabled and very cognitively impaired people, and that's going to be a major contribution, I think, to this population, the population in general.
Great, thank you. I see a few questions from our dean, Dr. Peak. So the first one that she put in the box is, has there been comparisons between the older adults and the MHAS with the older adults and the HAPIS, and in terms of mortality and morbidity outcomes?
I can take that one. So
Yeah, go ahead.
There's a small number of studies that have made comparisons between the MHAS and the Hispanic EPIs, but for the most part, the cross-national comparisons have been between the MHAS and the health and retirement study. One of the challenges of doing comparisons between the Hispanic EPIs and the MHAS are that the questions might be asked in a different way, and that can just change estimates and associations. But yeah, there's been some interesting studies comparing like the prevalence of diabetes and hypertension among adults age 80 and over, and that's compared Hispanic EPIs and Hamas participants. There's also been some studies that have looked at cross-national comparisons in cognitive functioning, in particular early life determinants of cognitive functioning. And that's used both studies.
But Brian, we also plan to, we are funded to add comparable measures to.
Yeah, that's a great point. Yeah, so I mentioned in my slides that we're enhancing the cognitive measures in the Hispanic EPIs, and we're intentionally selecting cognitive items that are in the MHOS and similar studies. So that would kind of lend itself to comparisons between the two groups using those studies.
Thank you for that. One other question is, what are a couple of hot topics from each of the studies that we talked about today that you would suggest that researchers study?
I can take that first. I've been thinking about that. Of course, so everything we said about climate change now will be we're going to be able to support those topics. Pretty much any topic you can think of, a health outcome with extreme temperatures or some of the other drought or environmental pollution. But the other things that we think we can now study, I think with both, is resilience. With both surveys that have a very long follow-up, then you can think about how resilience in the simplest definition is the ability to bounce back from negative shocks, right? And so by having a long follow-up in both studies, then you can look at resilience of the population and compare both in the HRS or in the Hispanic EPIs and the Mexican population as well. And now we have, of course, the major universal shock that we all got, which is COVID. And so being able to compare the trajectory of any pretty much health outcome before COVID and after COVID, and then we're going to follow after COVID, then I think resilience is going to be a very important topic to be able to identify those people who are resilient. Thank you.
Of course, is to do a better job of connecting our subjects, past and future, to neighborhoods. We have made some real good progress working with the University of Michigan, RICMA, Resource Center for Minority Aging Research. They have linked the Hispanic EPIs to a number of neighborhood data, in addition to just the simple demographic, which bring in all kinds of, climate related and also environmental issues. So we're very excited about that. We're actually publishing a special issue of the Journal of Aging and Health, which I edit. And we have a number of good papers linking our data with neighborhoods, which I think is going to lead to advances in how we progress in the future to do a much better job of linking where people live, their environments, both social and physical, to their well-being and their trajectories of well-being, health, and related well-being measures.
Thank you, Coco. So our final question here is about how people on the call can access the data. And I actually have a slide here with a thank you. And then I also included emails for both Dr. Marquides and Dr. Wong. I don't know if either of you want to add anything, any other information about how anyone on the call can access the data if they're interested.
Yeah.
Yes, we have the website was projected there when I was speaking, and in my thank you slide also provides the website. And like I said, it's a website in English and in Spanish, so people can download the data.
Well, you're more advanced in that than we are. We have a website also, and but feel free to contact me, and I will put you in touch. Our data archive with NACDA, which is the National Archive for Computerized Data on Aging, is funded by NIH. It's at the University of Michigan. and people can access the data there. And there are some issues in accessing them because they don't always have everything we have, but we are always willing to help with people and work with you and provide you better access. But again, just contacting me would work, and I'll be glad to help.
Yeah, same thing.
Great, thank you both. I'm gonna stop sharing slides, and I think that's all that we have. Jillian, I don't know if you have any announcements as we wrap things up.
No further announcements. That was great. Thank you so much. Super informative. And hopefully you all will receive a copy of the recording. We have all of the recordings for the entire series on deltaomega.org. And up next are the aughts. Thank you all.
Thank you.
Thanks.
Thank you, Gillian. Thank you, Leslie, especially.
Yeah, thank you all for your hard work putting this together. Bye now.
Thank you.